This is Lecture 10, Stroke, Seizure, Status Epilepticus, and CNS Emergencies. The ED job is rapid recognition, glucose first, time-sensitive reperfusion, and structured neurologic resuscitation. Time is brain, time is neurons, and the right diagnosis with the wrong sequence kills. The objectives are these. First, recognize acute ischemic and hemorrhagic stroke with last known well anchored. Second, apply thrombolysis and thrombectomy criteria. Third, manage status epilepticus with weight-based medication anchors. Fourth, recognize subarachnoid hemorrhage and posterior circulation stroke. Fifth, treat increased intracranial pressure and herniation physiology. Sixth, deliver empiric meningitis antibiotics with appropriate adjuncts. And seventh, avoid the classic neurologic board traps. The ED mindset for neurologic emergencies is time is brain. The first bedside test in any new neurologic deficit is glucose. Hypoglycemia mimics stroke. Last known well anchors thrombolysis and thrombectomy windows. The right diagnosis with the wrong sequence kills. Posterior strokes often have low NIHSS but high disability. Subarachnoid hemorrhage requires CT timing-aware sensitivity and sometimes lumbar puncture. Status epilepticus is underdosed at the bedside. Stroke recognition uses bedside tools. The fast mnemonic captures facial droop, arm drift, speech abnormality, and time to call. The BEFAST mnemonic adds balance and eyes to catch posterior strokes. The NIHSS quantifies severity from 0 to 42 and helps with thrombolysis and thrombectomy decisions. Board anchor numbers. A minor stroke is usually less than 4, and a large vessel occlusion is suggested by 6 or greater. The scale is weighted toward anterior circulation and can underscore posterior strokes. The first bedside test is glucose. Mimics account for 15 to 30% of suspected strokes. Hypoglycemia, seizure with Todd's paralysis, migraine with aura, conversion disorder, sepsis, and hyponatremia. Low glucose must be ruled out before pathway commitment. The acute ischemic stroke workflow is structured. Check glucose. Activate the stroke pathway. Obtain a non-contrast head CT to exclude hemorrhage. Add CT angiography of head and neck for large vessel occlusion assessment when thrombectomy is possible. CT perfusion or MRI may help in late window cases. Determine thrombolysis eligibility within window. Determine thrombectomy eligibility based on imaging and timing. Involve neurology and interventional neuroradiology early. Time is brain. Door-to-needle goal is 60 minutes for thrombolysis. Door-to-puncture goal is 90 minutes for thrombectomy. Thrombolysis for acute ischemic stroke uses alteplase or tenecteplase. The first drug is 0.9 milligrams per kilogram, with 10% as a bolus and the remainder as a 1-hour infusion. Maximum dose is 90 milligrams. TNK is increasingly used at 0.25 milligrams per kilogram intravenous bolus, maximum 25 milligrams. Single bolus, no infusion, which is why many centers are switching. Windows. 0 to 3 hours is the core window. 3 to 4.5 hours is the extended window in select patients, with 4.5 hours being the outer limit from last known well. Blood pressure must be below 185 over 110 before treatment and below 180 over 105 after treatment. If the patient is not getting reperfusion therapy, permissive hypertension up to 220 over 120 is acceptable. Use labetalol, nicardipine, or clividipine to control hypertension. Contraindications include intracranial hemorrhage on imaging, recent intracranial surgery, severe hypertension uncontrolled, recent significant trauma, active bleeding, and certain coagulation states. Classic board distractor, giving thrombolytics to a stroke mimic, hypoglycemia or seizure with Todd's paralysis. Check the glucose, take the history, do not light up a mimic with lytics. Mechanical thrombectomy is for large vessel occlusion. Criteria typically include an NIHSS of 6 or greater and an LVO confirmed on CT angiography. The standard window is up to 6 hours from last known well, extended to 24 hours with favorable imaging, small core, salvageable penumbra, using dawn or diffuse 3 criteria. ITE buzzword, mismatch between core and penumbra on CT perfusion is the late window trigger. Door-to-puncture goal is 90 minutes. The procedure is the most powerful intervention for LVO and improves outcomes more than lytics alone. The board concept is that the two are not mutually exclusive. Bridge thrombolysis is often given before the cath lab. Hemorrhagic stroke management is reversal, blood pressure control, intracranial pressure management, and neurosurgical involvement. Most common cause of spontaneous intracerebral bleeding is hypertension, and the classic locations are basal ganglia, thalamus, pons, and cerebellum. A lobar bleed in an elderly patient should make you think amyloid angiopathy. Reverse anticoagulation aggressively. Vitamin K plus 4-factor prothrombin complex, concentrate for warfarin, idarucizumab for Pradaxa, and Andexanet alpha for factor Xa inhibitors. Blood pressure target is below 140 systolic in most spontaneous cases, with careful titration to avoid hypoperfusion. Manage ICP with head elevation, hyperosmolar therapy, and sedation as needed. Call neurosurgery for evacuation candidates. Treat seizures if present. CT before any anticoagulation or thrombolysis is non-negotiable. Subarachnoid hemorrhage is the thunderclap headache you cannot miss. Classic presentation is sudden maximal headache, often called the worst headache of life. Associated features include neck stiffness, photophobia, vomiting, and altered mental status. CT sensitivity is over 95% within 6 hours of onset by experienced readers. After 6 hours, sensitivity declines. If CT is negative and suspicion remains, lumbar puncture for xanthochromia or CT angiography is the next step depending on pathway. That pigment takes about 6 hours to develop, so an LP done before that window can be falsely negative. Beyond 6 hours from onset, it is the high-yield finding. Hunt and Hess and Fisher scales guide prognosis. Management includes Nimitop 60 mg orally every 4 hours to reduce vasospasm, blood pressure control, neurosurgical evaluation for aneurysm clipping or coiling, and ICU admission. Posterior circulation stroke can present subtly and is underscored by NIHSS. Symptoms include vertigo, ataxia, dysarthria, diplopia, and weakness. Vertigo with neurologic deficit or new ataxia must raise concern. The HINTS exam, head impulse, nystagmus, test of skew, differentiates central from peripheral causes of acute vestibular syndrome. A normal head impulse, direction-changing nystagmus, or skew deviation suggests central cause. MRI is more sensitive than CT for posterior strokes, but is often unavailable acutely. The board trap is discharging a posterior stroke as peripheral vertigo. If the patient cannot walk independently, peripheral vertigo is unlikely. Seizure first moves are airway protection without forcing instrumentation, breathing support, circulation assessment, positioning to prevent injury, suction, oxygen, and glucose. Time the seizure. Most seizures self-terminate in 2 to 3 minutes. A seizure lasting 5 minutes or more, or 2 seizures without return to baseline between them, defines status epilepticus and requires immediate treatment. Establish IV access early. Send glucose, electrolytes, calcium, magnesium, pregnancy test in women of childbearing age, toxicology screen, and consider levels of anticonvulsant medications. Most common cause of new onset seizure in an adult is structural, tumor, or stroke. In children, the most common cause is febrile seizure. Psychogenic non-epileptic spell, PENS, clues, forced eye closure, asynchronous limb movements, pelvic thrusting, and no post-ictal phase. The status epilepticus algorithm is time-driven. 5 to 20 minutes is the first phase. Give a benzodiazepine. 20 to 40 minutes is the second phase. Give a second-line anti-seizure medication. Beyond 40 minutes is refractory status and requires intubation. Continuous infusion of midazolam, propofol or pentobarbital, and continuous EEG monitoring. Each step has a maximum dose and a transition criterion. Underdosing the first-line benzodiazepine is the classic failure point. The board principle is that status epilepticus is a time-critical disease and delays kill neurons. Seizure medication anchors are weight-based. Lorazepam 0.1 mg per kilogram intravenously, maximum 4 mg per dose, may be repeated once. Midazolam 10 mg intramuscularly is excellent without IV access, equivalent to IV lorazepam in studies. Diazepam 0.15 to 0.2 mg per kilogram intravenously or rectal 20 mg. Second-line medications include levetiracetam, Keppra 60 mg per kilogram intravenously, maximum 4,500 mg. Phosphonetoin 20 phenytoin equivalents per kilogram intravenously, and Valproate 40 mg per kilogram intravenously. The board concept is to underdose nothing. Skimping on benzos causes refractory status. Classic board distractor, phenytoin or phosphonetoin as first line. Wrong. Benzodiazepine first, every time. Phenytoin only enters the algorithm in the second phase after the first dose has been given. Refractory status epilepticus is failure of first and second line therapy. Management is intubation with rapid sequence induction, continuous EEG monitoring, and continuous infusion of an anesthetic agent. Midazolam infusion at 0.2 mg per kilogram bolus, then 0.05 to 2 mg per kilogram per hour. Propofol at 1 to 2 mg per kilogram bolus, then 20 to 200 micrograms per kilogram per minute. Pentobarbital for super refractory cases. The target is burst suppression on EEG. ICU admission and neurology consultation are required. The board principle is that refractory status requires definitive airway and continuous EEG. Increased intracranial pressure is an emergency. Signs of herniation include declining mental status, unequal pupils, posturing, and the Cushing response, hypertension, and bradycardia. Immediate management includes head of bed elevation to 30 degrees, neutral neck position, avoidance of hypoxia and hypotension, and treatment with hyperosmolar therapy, mannitol 1 gram per kilogram intravenously, or hypertonic saline, 3% saline 250 milliliters bolus, or 23.4% saline 30 milliliters via central line. Maintain serum sodium between 145 and 155. Hyperventilation temporarily reduces ICP through hypocapnic vasoconstriction, but is a bridge only. Call neurosurgery immediately. Bacterial meningitis is an emergency. The classic triad is fever, headache, and neck stiffness, but all three together are uncommon. Assume meningitis when any two are present and the patient looks ill. Most common organisms, strep pneumonia is number 1 in adults. Neisseria meningitidis is the outbreak organism in young adults in dormitories, and Listeria covers the over 50, immunocompromised, and pregnant patient. Lumbar puncture findings of high opening pressure, low glucose, high protein, and high white blood cell count with neutrophil predominance are characteristic. Empiric antibiotics should not be delayed for imaging or lumbar puncture in critically ill patients. Adults, ceftriaxone 2 grams intravenous plus vancomycin 20 milligrams per kilogram intravenous. Add ampicillin 2 grams intravenous for age over 50 or immunocompromised. Listeria coverage. Add acyclovir if herpes simplex encephalitis is suspected. Dexamethasone 0.15 milligrams per kilogram intravenous given just before or with the first dose of antibiotics reduces mortality and neurologic sequelae in pneumococcal meningitis. Eclampsia is seizure in pregnancy or postpartum, up to 6 weeks, attributed to preeclampsia physiology. Magnesium sulfate is first line. Loading dose is 4 to 6 grams intravenous over 15 to 20 minutes, then maintenance 2 grams per hour. Treat hypertension to below 160 over 110 with labetalol, hydralazine, or nifedipine. Deliver the baby. The board concept is that magnesium replaces standard anti-seizure medication choices in eclampsia. Press, posterior reversible encephalopathy syndrome, and CVST, cerebral venous sinus thrombosis, are pregnancy-related entities to keep on the differential. The neurologic board traps are predictable. Forgetting glucose as the first bedside test in any neurologic deficit. Under-recognizing posterior stroke because NIHSS is low. Underdosing the first-line benzodiazepine in status epilepticus. Delaying second-line anti-seizure medication when status persists. Missing eclampsia in a pregnant or postpartum patient with seizure. Performing lumbar puncture before CT when intracranial pressure risk is high. Discharging a thunderclap headache after a single negative CT. And missing dexamethasone with the first dose of antibiotics in suspected pneumococcal meningitis. A single negative scan is the wrong stopping point for that presentation. Case 1. A 65-year-old presents with vertigo, vomiting, ataxia, and dysarthria. NIHSS is 2 for dysarthria. The patient cannot walk independently. Bedside HINTS exam shows normal head impulse and direction-changing nystagmus. This is posterior circulation stroke until proven otherwise. Activate the stroke pathway. CT plus CT angiography. Consider thrombolysis within window. Thrombectomy if basilar or vertebral occlusion confirmed. The board trap is discharging as peripheral vertigo. Case 2. A 30-year-old has been seizing for 7 minutes. IV access is difficult. Give midazolam 10 milligrams intramuscular now. Prepare lorazepam 0.1 milligrams per kilogram IV when access is available, max 4 milligrams. If seizure continues at 20 minutes, load levetiracetam 60 milligrams per kilogram intravenous or fosfonidin 20 PE per kilogram intravenous. If refractory, intubate and start continuous infusion. The board trap is waiting for IV access while neurons die. Question 1. A patient presents with a stroke-like deficit. What is the first bedside test? The answer is glucose. Hypoglycemia mimics stroke and is rapidly reversible. The board trap is going straight to CT before checking glucose. Question 2. A patient has been seizing for 6 minutes and IV access is difficult. What is the next best medication? The answer is intramuscular midazolam 10 milligrams. Studies show imidazolam is equivalent to IV lorazepam for status. The trap is delaying treatment for IV placement. Question 3. A patient has a thunderclap headache. Non-contrast CT done 8 hours after onset is negative. What is the next step if subarachnoid hemorrhage suspicion remains? The answer is lumbar puncture for xanthochromia or CT angiography depending on local pathway. The trap is discharging after a single negative CT when timing and clinical suspicion warrant further evaluation. The final takeaways are these. Glucose is the first bedside test in any neurologic deficit. Last known well anchors stroke treatment windows. Thrombolysis door-to-needle goal is 60 minutes. Thrombectomy door-to-puncture goal is 90 minutes. Hemorrhagic stroke requires aggressive reversal and blood pressure control. Subarachnoid hemorrhage CT sensitivity declines after 6 hours. HINTS exam helps differentiate central from peripheral vertigo. A low NIHSS is the wrong reason to rule out stroke. Status epilepticus is underdosed at the bedside. Use weight-based dosing. Refractory status needs intubation and continuous EEG. Increased ICP gets head elevation, hyperosmolar therapy, and neurosurgery. Eclampsia gets magnesium. Bacterial meningitis gets antibiotics within the first hour with dexamethasone. References for this lecture include Rosen's Emergency Medicine, 10th edition, Foundations of Emergency Medicine Board Review, the American Heart Association, and American Stroke Association Guidelines for Acute Ischemic Stroke Management, the Neurocritical Care Society Guidelines for Status Epilepticus, the Dawn and Diffuse 3 trials for late window thrombectomy, the Infectious Diseases Society of America, Guidelines for Bacterial Meningitis, the American College of Obstetricians and Gynecologists Guidance for Hypertensive Disorders of Pregnancy, and the Hunt and Hess and Fisher scales for subarachnoid hemorrhage. Local stroke pathway, neurosurgery, and neurology protocols guide site-specific decisions.